who has very kindly travelled all the way from the US of A, more specific Boston, to address the conference today. Maureen has 30 years experience in peri-anesthesia. In 2012, she progressed to clinical nurse specialist of procedural sedation, working for Department of Anesthesia on the acute pain service. In 2013, she became clinical educator, surgical and cardiothoracic intensive care unit, and in 2015, she joined the Division of Anesthesiology and Acute Pain Service as the Quality Nurse Specialist. Again, you're very busy, Maureen. An active member of American Society of Peri-Anesthesia Nurses, she is also the international liaison for the Irish Anesthesia and Recovery Nurses Association. So indeed, we're very lucky. Today, we will learn about malignant hypothermia, the historical journey, reviews of retrospective studies of data reported to malignant hypothermia registries, and shares one institution's journey to make malignant hypothermia a focus of nursing and provider education in all areas where trigger agents are used. And we also just want you to note that there's a quiz on the subject in your booklets. You don't have to hand it in, and it's not a test per se, it's a self-assessment. So put your hands together for a warm welcome for Maureen.
Good morning, everyone. Again, it's such a pleasure to be here. It is my second opportunity to present for this wonderful organization, and I thank your program planning committee for allowing me to come. Just a very quick question. How many in the audience have experienced either through their professional life or perhaps personal life a malignant hypothermia episode? So a few people. As I began this journey, I came to the realization in my institution, I am the only person who has actually participated in a real malignant hypothermia event. I've been practicing in peri-anesthesia world for 34 years. I remember the case. I started in 1983 in a PACU. It was in the late 1980s. I remember it distinctly. I remember it was slot 23 in our PACU. I remember the anesthesia staff. I was still a relatively new nurse, and my role was the saline lavage, but I remember it. None of the anesthesia staff that I work with has ever participated in a real event, and that was a very interesting part of our journey. So why malignant hypothermia in 2017 should that be a hot topic? We screen patients, we ask them in pre-admission testing, any personal family history of malignant hypothermia, and we go forward. So the personal journey, I'll get into the details a little bit later in the presentation, but within the United States, as you perhaps know, we have regulatory agencies that come to visit and either approve us or don't approve us, and it has come to their attention that we need to be focused on malignant hypothermia because there are still deaths within the United States, across the world, from malignant hypothermia, and the surveyors want to know, what are you doing to make sure that you are well equipped to handle it should it occur? And as part of my role within the anesthesia department, it became my job to ensure that our facility was equipped to handle that emergency. This is a true story. It is from the United States. A case study, an 18-year-old, otherwise healthy female, heading off to college. She had a defect, a cosmetic type defect in one of her breasts, and she chose to have elective surgery prior to heading off to college. She's a lovely young woman. So elective outpatient. So again, in the United States, there are several freestanding surgical centers that very often are attached conceptually, but not geographically, to a tertiary hospital. This is a freestanding outpatient surgery center. The family had interviewed many plastic surgeons. They chose this one, and away this young lady goes. And 2 hours into the operation, she developed hypothermia. She was transferred to acute care hospital, and she died in 24 hours. The audio from the 911 call is available on YouTube. I did not load that in. It is unclear whether the facility had any dantrium or dantrolene or simply not enough. but she passed. That's another reason why we still need to keep this on the forefront of our attention. There was no family history. She was screened. There was no herself or her family, any family history in their extensive family. There was no previous anesthetic for the patient, and there was not enough dantrolene available, is the summation that I was able to get from reading. So a little bit of background. All of us, I think it is safe to assume in the room, have received education and training on the management of malignant hypothermia. So in my research journey, I learned quite a bit. I thought it was interesting. So what do we know? We know it's a syndrome of constellation of signs and symptoms. It is a pharmacogenetic hypermetabolic crisis resulting or due to uncontrolled release of intracellular calcium. What is interesting in the journey is that the first case was determined in 1922. In 1938, Dr. Goodell identified 6 cases of postoperative hypothermia. All died. Was it related to the ether? And then in 1960, Dr. Denborough in Australia began really what is the journey that culminated in our status in 2017. He was part of a team that cared for a 21-year-old male who had a traumatic fracture. And this young man was able to say, you know, lots of my family have died from anesthesia. I'm worried about my anesthesia. And they said, well, we don't want you to die. We're going to make very sure that you have a good outcome. So we're not going to use ether. We're going to use this new medication called halothane. 10 minutes into the anesthetic, the patient was cyanotic, hemodynamically unstable, and hot. The halothane was turned off. The patient was packed in ice that was immediately available in another operating room where they were having heart surgery. The patient was packed in ice, and he survived. This is a letter to the Lancet in 1970. The author is Dr. Denborough, and it is biochemical changes in malignant hypothermia, and he's talking about this particular case. So keep in mind, 1960 to 1970, did they have email? Do they have professional organizations where they met every year? Did they know each other? So what was learning across the world is that Australia, South Africa, Dr. Goodell in Germany, there were colleagues in Canada and colleagues in the United States, all identifying there are young people dying of anesthesia, and we need to do something about it. In the subsequent case in Australia, again with the same team, there was a postoperative death within 24 hours of the anesthetic. They had identified muscle rigidity as a component of the anesthetic, and they determined to check the CK level on that patient, and it exceeded 20,000. They went further and said, we need to check the CK levels of the family members, not under anesthetic or post-anesthetic, but we want to check those CK levels. And they identified that those family members tested positive with elevated CK levels. In Canada, Dr. Britt and company started to look at muscle contracture tests because muscular rigidity was determined to be the commonality of all of these anesthetics and the beginning of the caffeine-induced contracture test, which exists today. In 1998, again, really very quickly, genetics played a role, and the R1 ryanodine receptor was identified as the genetic linkage, and the ryanodine receptor is responsible for calcium release from the sarcoplasmic reticulum. So Dr. Britt from Canada, who's now passed but did tremendous research, did a statistical review of known cases, and at that time the majority, 60 to 70% of any case, the patient succumbed and did not survive, and did as much research as was available at that time. They determined that, again, these early anesthesia providers determined that there is a linkage between patients with a myopathy and malignant hyperthermia, and there were 3 that they determined in the early years. One was called Evans myopathy. It was named after a specific patient. Subclinical, common with lower extremity muscle wasting. The King-Denborough, again, Dr. Denborough syndrome, identified children, mostly male children, small for age, undescended testes, lumbar lordosis, and unusual facial composition. And those presentations of that patient with or without experience or family history to anesthetic increase the potential risk for malignant hypothermia. And then central core disease, which is a persistent muscle weakness, and that remains true today, that any patient with central core disease is at risk for malignant hypothermia. The diagnostic methods that were identified, first, clinical presentation, which would lead to testing. The second was in vitro contracture test, and this is from EMHG, as the European Malignant Hypothermia Group, and they determined sort of a pathway. Malignant hypothermia sensitive if both caffeine and halothane contracture tests were positive, negative if both cases were negative, and sensitive if either they were positive with halothane or caffeine if they separated out the tests. And it was determined to be sensitive for 99%, so if you're positive, and the specificity of 94%. If you're negative, you're truly negative. So very good data. The caffeine halogenated contracture test, which is from the North America group, similar, only 78% specificity, which means you can have some false negatives and false positives, so not as accurate. What are the current limitations, and certainly at least in the United States, with doing this? Money is not covered by insurance, and only a few centers are doing it. It is a surgical procedure, et cetera, so somewhat have fallen off the wayside for testing. What about genetic testing? Awesome. Blood specimen, very specific, looking for the RYR1, present in 50 to 70% of patients who are malignant hypothermia sensitive. There are many variants, but nonetheless a very good test. What are the other challenges, without getting into the details of genetic testing? Expensive, and who has access to that information? So RYR1, a defective calcium channel, is present in malignant hypothermia or individuals who are exposed to a triggering agent, and the pathway and the way that it operationalizes is a rise in myoplastic calcium 3 times the normal amount, a sustained muscle contraction, as you know, breakdown of ATP, lactic acidosis, increased carbon dioxide, increased temp, depletion of ATP, so you have cellular death, leakage into the extracellular fluid, so the massive, as a cell dies, the intracellular potassium is released and you have profound acidosis, myoglobinuria, and the death, if the chain, a cycle is not broken, the death is a result of cardiac arrest, brain damage, disseminated intravascular coagulation, and solid organ failure, mostly the kidneys. So that's the sequelae. Very busy slide that you won't be able to read, but that's somewhat the journey. Unless we interrupt the cycle right up in the beginning, that's cascade results, and the cause of death at present in the cases that patients have passed very often is DIC, a disseminated intravascular coagulation. For those who survive, some are left with the organ failure, largely renal from the myoglobinuria. So a case study in 1979, dantrolene for malignant hyperthermia. And this is its own extraordinary journey. 1979, dantrolene was not developed for malignant hypothermia. It was developed for spasticity. It was a direct-acting muscle relaxant. And lo and behold, a group of physicians realized, well, let's try this on these patients, and a miracle occurred. And it was the antidote for malignant hypothermia. It decreased the mortality, which at that point was 70 to 80%, down to less than 10%. It blocks the calcium release from the sarcoplasmic reticulum. It reduces or eliminates the sustained contractions. The dosages are 2.5. Right out of the gate, they determined, actually, when they do the retrospective studies, right out of the gate, they were pretty right on for the dose, 2.5 milligrams per kilogram load, until the acute phase has passed, so the clinical signs are abating, the tachycardia, hypercarbia, or hemodynamic instability. You can go up to a recommended dose of 10 milligrams per kilogram, but you continue until the symptoms abate. However, if you have given more than 10 milligrams per kilogram, now that sepsis is a diagnosis, you might want to consider some other causes for your hyperthermia and instability. And the limitations to the dantrolene, cost, and the challenges with reconstitution of the early forms of dantrolene sodium. So now we are 2017. So what has made malignant hypothermia rare, not that common, and made it survivable some of the time, most of the time? We screen patients, pre-admission testing. All of us. Before a patient has an anesthetic, do you not ask, have you or a family member ever had complications with anesthesia? Right. That should do it, right? That should do it. Not enough. Routine measurements of end-tidal CO2 in the operating room. Again, I've practiced for a long time in an era where we didn't always do that. So yeah, that's definitely, because that's an early sign, so absolutely, we're going to catch it right on. Recognition of early signs of MH. So keeping in mind, there is actually no laying on of the hand to say, I think you have malignant hypothermia. What do we know? Tachycardia, hypercarbia. What do? Adjust your minute ventilation, turn up the gas, treat the tachycardia. The first thought that comes into your mind, because it's a tough decision, this patient has malignant hypothermia, we need to abort this anesthetic. No. You change a minute ventilation to try and do a few things to see if you can recover those signs. And the presence or existence of dantrolene sodium. So I'm assuming at least most of you have that in your institution and know where it is and know how to use it. That was the beginning of our journey. Has the rarity mitigated the risk? It has not. So dantrolene, known treatment, been around now for many years. It is not always available. Not in every location, not in every country. Minimum alveolar concentration required or necessary to elicit a trigger of a volatile anesthetic? Don't know. We know that a volatile anesthetic is a trigger, but we don't know how much of it or for the duration is required before there's a trigger. Non-anesthetic triggers that the time does not allow me to get into our challenges with our ED colleagues and heat-related non-anesthetic events of MH, but there are MH events that occur without exposure to a triggering agent. Some have eliminated the use of succinylcholine, anectine, or succinylmethonium. Our facility actually explored that in the emergency room. Do we eliminate the use of sucks, and therefore we've reduced the potential by at least 50%. But where else are we in 2017? The MH registries of patients who survived or who were thought to have an MH event, that data is populated in both in the United States and in Europe. So it allows retrospective research, which gives us more data. There are other databases, at least in the United States, between closed claims, which means something bad happened and someone wants to sue, patient deaths, unfortunately, and insurance companies. And so what do we know now as we're going forward with research? Incidence of MH reactions in adults, 1 to 10,000, 1 to 250,000. Prevalence. When doing the research for this, there's a wide variation in the question of prevalence, i.e. people who have the potential, genetic carriers, potential to have an MH event, as low as 1 in 400. But several of the articles cited 1 in 3,000 individuals. And the mortality, which used to be quite low, recent research has shown the mortality is up as high as 11%. The retrospective research studies use a MH clinical grading scale. In other words, they don't just take the fact that you had MH or you maybe had MH and your case was canceled and here's what happened. They don't just take that at face value. They actually have a point structure to assign points to that review to increase the sensitivity for an actual MH event. And they focused on rigidity and muscle breakdown and respiratory acidosis as the higher point structure. So this was a publication in 2010, clinical presentation, treatment and complications of MH in North America from the North American Registry. Their N number was 286 cases, 75% were male, 70% was Caucasian, which is common in almost all the studies. 30% had a very muscular build. The mean age was 22. 50% had more than 2 prior unremarkable anesthetics. So the question on your pretest, if you've had a safe anesthetic, you don't have any risk for MH, that would be false. 50% had more than 2 or more than unremarkable anesthetics. The clinical signs, MMR is masseter muscle rigidity, hypercarbia, sinus tachycardia, as we know, elevated temp, and skin mottling cyanosis. Elevated temperature is a late sign of MH. Not in this research study. Elevated temperature was shown to be one of the first three signs. Elevated temperature and rapid rise in temperature. Recrudescence, or which is when the MH event reoccurs within that same patient. So you have the acute onset, you treat it with dantrolene, and then recrudescence is when it occurs again. Estimated to be 25% in that study. The patients were sent to the ICU for ongoing monitoring and care. The temperature correlated to the development of DIC, so temperatures greater than 41 degrees were more likely to develop the disseminated intravascular coagulation. RF is renal failure. We know that that's a risk. And rhabdomyolysis due to the muscle breakdown and elevated CKs were common. So they identified, as we know, the need for ongoing dantrium management, and the ongoing is 1 milligram per kilogram every 6 hours or as needed based on clinical signs. In another study, malignant hypothermia deaths related to inadequate temperature monitoring. This particular N number was 84. The death rate was determined to be 95%. And unfortunately, I don't think I'm going to leave the mic for just a second, just point out something on this. And hopefully some of you can see If you look here on the right where the circles are, and there's a cross with the circles, those are patients who died. The ones in red, there was no temperature probe. The ones in blue, there was a skin probe. And you don't see any green off on the right side. Green is a core temperature. So there is a message with this research study. So the data that they showed, 7 cardiac arrests, 8 deaths, 50% occurred in freestanding facilities. All of the deaths were associated with more than 30 minutes of anesthesia. The time to the adverse signs was 60 to 199 minutes. The mean temperature is here at 41.6 degrees or 107 degrees Fahrenheit. Malignant hypothermia was identified in the OR in 7 out of 8 cases. 1 was in the PACU. 6 had post-mortem positive genetic studies who had confirmed that, yes, this was a malignant hypothermia event. And the conclusion, temperature monitoring for cases lasting longer than 30 minutes. We don't have that exact same standard of care in my operating room, and though we're discussing it. So I learned something from this study. Trends and outcomes. Another publication, this was a little bit of a different study. This was from insurers. Their N number was pretty good. It was 2,553 cases. Mortality, 11.7%. The increased risk of mortality were patients with more comorbidities, i.e. they wouldn't survive an insult. Rural hospitals out in the country versus more a city setting. Emergency room admissions and transfers. What do we know about emergency room admissions? They're sick. Inadequate time to screen. These are not the patients that go to pre-admission testing centers. So emergencies and transfers from other facilities, older age and female gender, while not more likely to have MH, were less likely to survive it. In 2014, there was a MH in children study that was very interesting, a retrospective study of 264 cases, and they put the children into 3 cohorts, 0 to 24 months, 25 months to 12 years, and 13 to 18 years. So it was a cohort study to determine, do children who develop MH survive or possibly have MH, do they have different clinical presentation? Well, they all had tachycardia and hypocarbia, but yes, they did have some differences. The older group developed a very high fever, rapid rise in fever, high peak CKs, determined to be because they have a muscle mass. These are teenagers, they have a muscle mass. Hyperkalemia was common. In the babies, they developed acidosis, not so much a spike in temperature, but they developed acidosis rather quickly and a higher lactate level. And the 25 months to 12 years had the masseter rigidity, but less of all of the other signs. The outcome, unfortunately, there were 10 deaths, none, fortunately, in the babies, 6 and 4 in the other groups. Only 50% received the dantrolene, and the recrudescence or the reoccurrence was 14%, and of the 14% in that group, 2 did not survive. Anesthetic drugs, isoflurane, this is another study that was done. Isoflurane has a higher incidence of, it's a heavier gas, longer gas, stays in your system longer, more associated with MH. And MH onset time in the presence or absence of SUX, if you combine the 2 together, higher percentage and faster onset. So my personal journey, at the time I had left, my personal journey with my institution began in March of this year. We had what we call a mock survey, so we pay people to come in as a consultant and tell us where we succeed and most really where we fail. And we knew that they would come in with a focus on malignant hypothermia. We were somewhat prepared for that discussion. And they went immediately to an area in our radiology department where we treat kidney stones. And they went right to that area, identifying that was anesthesia out of the OR, and they asked a young lady that was in that area, tell me about MH. She's a radiology technologist. She didn't know anything about MH. She's trying to answer the questions. Well, how would you get the MH card here? She didn't even know what it was. So we somewhat out of the gate failed. And it came to the unfortunate conclusion on my part that I need to create a task force and we need to tackle this problem. So I convened a task force on March 1st with a very full room, great eagerness on the part of my colleagues to have this discussion. And anesthesia, obviously, and I had an anesthesia chair, OR, PACU, critical care, obviously, because these patients can go anywhere, radiology, including technologists, pharmacy, all procedural areas in our emergency room. We identified that we had outdated resources. We're blessed in the United States to have the Malignant Hypothermia Association of the United States. We're blessed with that. And we had the old binder. So we spent a couple $100, got new things. Staff education we determined was inconsistent. And the dantrolene in the journey with our freestanding surgery center, once I headed down the path of perhaps teaching the fire department how to mix dantrolene, I realized this is not going to work, and we actually need a newer product. We went to simulation, and I'm going to show you just in the next slide exactly what that looked like, and I had a stopwatch and timed the identification of MH for the first dose of dantrolene. It was recommended by organizations that it be within 10 minutes. The call for help, who did you call and can they find you, and anesthesia, what and where are their resources. So MH drills, simulation drills with portable mannequin. Did it in the procedural areas. There was an anesthesia lead, one of my colleagues, and it simply was a general anesthetic case. Patient had no history of malignant hypothermia, so he shares that. And tachycardia, exhaled CO2 with the first sign, so it's built into the simulation manual, simulation mannequin. The CO2 hits 70, and then the anesthesia provider says, I think we have MH, and this is to the group. Now, this is a planned drill. Everybody knew that what we were doing. The next phase is going to be unplanned, so it's blinded, but everyone knew. Anesthesia says, I think we have MH. And I've got the stopwatch. This moment he said that, stopwatch goes. What's the first thing you do in an MH crisis? First thing, call for help. So we drilled that. The rest you all know. You stop the triggers, you abort the case, you hyperventilate. So we all of us, I think, are very competent in that. I timed time to first dose, and the rest. We did not get into how do you treat hyperkalemia, the isaline, but we didn't get into that, but we certainly reinforced what you needed to do. This is a drill sheet, and it came literally right from the binder from M-House, and this is one for radiology, and I timed the arrival times, and here are the comments. The OR staff was unsure of the location, so the conclusion when we did our debriefing is recommend having someone not just out in the hallway, but in a central location, because there are two accesses to IR. So came up with something. Who was leading the MH code? Nursing commented it's different than an ACLS code, and it wasn't clear to them who was driving the bus. MH resource binder, which I had developed, was underutilized, so in fact there were instructions there on dosing and mixing and weight-based, but the binder remained closed and staff were kind of fumbling, and concluded good practice to mix the dantrolene, you need a team to do it. From anesthesia, the crisis manual was missing, so the anesthesia team that was there, even they kind of paused, what do I do first? OR brings the MH card, as I already said. So a couple of different challenges. We have automated medication dispensing devices in a code in the MOC code. In endoscopy, they've had trouble removing the binder and the starter kit of the dantrolene. So all sorts of different challenges that we identified, which just reinforces the importance of simulation. Our journey with dantrolene, we still stocked dantrolene or Revanto, which is the powdered 20 milligram vial that requires 60 cc's to dilute and requires time. And we did have subsequently a meeting with pharmacy, and we do now have Ryanadex, which is the much more expensive version, but it's much easier to mix. It's 5 cc's of sterile water, and each vial contains 250 milligrams, so it can cover ideally a 100 kilogram patient right out of the gate. So we have now stocked that. Anesthesia workstations are protocols for each machine type. In an active MH event, you have to disconnect. Everyone knows you shut it off, you turn on 100% O2, you abort the procedure, and you clear the residual gas. What was not well known with the younger providers that I have is about charcoal filters. So I have had these discussions recently, and where would you like the charcoal filters? We're going to put them in the MH cart. What do you think? And several of them have said, why do I need a charcoal filter? I said, well, you know, you're going to attach it to your machine because the charcoal filter on your inspiratory and expiratory component of your anesthesia machine will trap any of the gas and decrease it to less than 5 parts per million. And they said, well, I'm just going to imbue the patient. So there's even work within our anesthesia team and simulation that is needed for that. This is too busy of a slide, but it is guidelines for the use of activated charcoal filters for a patient that is either an active event or a susceptible event. And then a guideline, and again, I'm sorry you're not going to be able to see all of it, but what do you do if you are aware that the patient has a family history or themselves a history of malignant hypothermia? How do you treat your anesthesia machines? We talked about it over dinner last night, and one of my colleagues here from America at a very large teaching hospital in Boston, well, they have, the sterile anesthesia machine that is free and has never had any gas to it. Well, we can't do that. All of our machines are in circulation, so we need to treat a machine, pre-treat it, before it can be attached to a patient. And how do you go about doing that? And so for all of us in the room who are directly involved with that, you need to know the manufacturer's recommendations, and they vary. There are resources available, both in the United States, the European group, and in the UK. Tremendous online resources where we are in 2017. We may not have solved the problem, but we certainly have a lot more knowledge and information than we had before. For those who survived, in other words, had an MH event, were treated with dantrolene sodium, for those who survived, some common complaints are headaches, muscle aches, tired and weak, all of which I think we can understand, numbness and weakness in their legs, memory loss. There's a commonality, memory loss. And why we still review. These are the images of young people who have died. This is from the United States, 2008, 2005, and 1990, an athlete from the U.S. volleyball team. We can save every life, but we need to be prepared for it. We need to understand that the fact that a patient or a family member has either had a successful anesthetic without a problem, perhaps never had an anesthetic but has no family history, is insufficient. It's a great starting point, but each case, each time, we need to start with MH is a possibility, and we need to be prepared. Thank you all very much.